Welcome to another episode of Underprepared. It's nice to be back, Luca.
Always nice to be invited back to your podcast, John. Thank you. Thank you for having me.
We've got a lovely case today. So this is a beautiful case that you've treated in recent months here in the clinic. It's an upper right central incisor case on a youngish patient that traumatised it. And we thought it'd be a really interesting case for you to walk through and let us know what you did, really.
Yeah, I think we had to think outside the box a little bit with this one, and we were very lucky we had the whole digital setup for this, and I think it was invaluable for trauma cases like this. So this is a young 17-year-old male who unfortunately had an accident and had a shear fracture of the upper right one. And this was this presentation at the second appointment. So the first time we saw him, that fragment was attached to the soft tissues. It was just held in place by PDL. And then what we did is we scanned the mouth with the intraoral scanner and planned the treatment. So this was at the second appointment when he was all nice and numb, and we just removed the fragment that just was held in place by pulp tissue. And that, what you can see is the soft tissue continues with the pulp.
Yeah, I mean, it's quite an impressive fracture, this, isn't it? And in terms of your diagnostic sort of workup here, when you saw the patient initially, what was your approach to this?
Well, I had to, my main thinking process was how can we restore him? And unfortunately, the fragment wasn't fitting back to where it should be. So we scanned intraorally to do a digital wax up of the teeth, so recreate his natural smile and occlusion. And what we did with the help of Colin, who works with us as a restorative dentist, and he did a mock-up, designed it, we 3D printed it here, and then we did a suck-down splint, see-through splint, so that we could do a direct composite build-up. So that was sort of, I remember we sat down and had a little think about how to build him up all in one appointment, because we want to give these patients something to walk out with, which is as natural as possible, really.
In terms of the patient, what sort of symptoms were they? Obviously, they're presenting with a very loose tooth at the front. In terms of the pulpal symptoms, how was his kind of pain from a pulpitis perspective?
Nothing, absolutely nothing. It was uncomfortable because, as you said, the tooth was loose. It was an infraocclusion, but actually, pulpal-wise, absolutely nothing, which a bit sensitive. That was some sensitivity from the error, but it just gives you an idea of how great the pulpal complex is. It's fantastic, really resilient, amazing.
I thought as well, I know when we were looking at this case, the cone beam CT scan, I always found these images quite remarkable. You can really see that displaced, labial fragment there. And as you say, it was just attached by that little bit of PDL that was there. What were you looking for specifically on the cone beam to take a cone beam here?
Yeah, a couple of things. And one of the reasons for taking the cone beam is making sure there weren't any apical fractures and apical cracks, because all of a sudden that changes the way you plan the treatment. And all of a sudden, going from trying to maintain the tooth, you start thinking, well, should we just lose that? And I remember looking at this together, and you can see that palatal aspect of the one. There's a little bit of PDL widening palatally, and I think it's because the whole axis of the root ever so slightly inclined because of the trauma, which meant that the fragment itself wasn't reapproximating the right place anymore. So I take these scans for multiple views to assess the angulation of the roots, any cracks, any alveolar fractures, and actually, given the impact, making sure that the other teeth don't have any other apical fractures.
Yeah, I agree. I mean, I think there's such value in cone beam in trauma patients. And with these younger patients, you kind of alluded to it there, they're quite complicated decision-making, treatment planning cases here, because this guy was, how old did you say?
He's 17.
17. Yeah. So, they're not quite in that window of implant dentistry yet. And you think, well, if you're going to lose the tooth, what's his option? It's going to be maybe bury it, place a resin bonded, so you're coming back for an implant later. Or actually, I think, what you did, you're certainly, it's not going to be a forever tooth, this, but you're buying an awful lot more time to get him into kind of a sensible restorative window, really, with it.
And I think as we see the next images, it's there's a lot of things that we've learned from this case, not only from a planning perspective. So this was the 3D printed tooth and smile effectively. So the upper right one, what Colin did is he mirrored the upper left one. So effectively it's the same tooth but flipped around. It gives us a bit of symmetry. And then we created a suck down splint, so see-through splint. So this was the palatal view, and it's really, we don't see this often. And what's really useful here is from a planning perspective, you can see how deep his overbite was.
Yeah.
And all of a sudden you realize that what you're trying to build may not last, not necessarily because of what you've done, but because of occlusal reasons. So all of a sudden you go from, let's just stick something there, to what are we planning long term to protect this restoration, whether it's a composite, a crown, or an implant. So this was really useful to see what we're planning, and Colin was helping us decide how we're going to protect in terms of slides and protrusion.
So you said you made this suck down that we can see here on the slide. What was this made of, and were there any sort of special features that you put into it in terms of the restorative kind of forward restoration that you're going to put on the tooth?
Yeah, so this was it's a see-through material, which is really useful for what we're going to do next, which is building it up in composite so we can light cure through it. So this was a GC material. Yeah. And actually, we've highlighted the channel that I drilled through the splint. So there's a little channel through the splint that goes all the way to the tooth in question, the upper right one. And that is a bit of an escape route for the air, because when we place the splint in place, we want some of the air to escape and potentially some composite excess. But as we go through the case, you'll see, and this is far from a perfect case. I mean, it was a first trauma, digital design case all at once. And there's lots to take away. And in this case, if I was to redo the channel, I would make it smaller. So you want less air escaping, because you do want to keep some pressure as you're pushing it down. So as you'll see the next steps, I think I didn't have enough pressure created from the splint while seating the composite. So
that's the beauty of documenting your work like you have done here, is that reflective approach to things is so valuable. We're going to, obviously this comes back to the original presentation, just to bring ourselves back into where we were with the case. We've got to get into a bit of endo, because we do love a bit of endo. So I'm looking at this and I'm thinking, this is going to be quite a challenge to isolate. I mean, what have you got here? You've got pulp tissue.
Yeah, it's a bit of both. Right. You tell me. It was pulp tissue and a bit of gingival tissue. So what I did very simply, I resected the soft tissue. It was excess. It's a polyp, if you want to know, that's what it is. So I resected that, did a small envelope flap here. So no relieving incisions, just loosened the ligament around the upper right one to give me a bit of space to push those gums away and be able to put a clamp over the top. So this is me just retracting that bit of tissue. And you can see that line, which is where the fragment just popped off. Yeah. So shear fracture. This is a butterfly clamp, 9A, really nice, sharp, small teeth, slightly offset, so really allowed to grip what was left there. And I think if it was sliding off, what we often do is we put a little composite tag across that labial aspect so that the teeth just engage under that.
Yeah, exactly that. Or just get a pair of ortho pliers and really evert the clasp tips. But I think you're right, the number 9, the butterfly clamp, is absolutely perfect for this type of isolation. It's amazing, isn't it? When you go back to think about the previous slide with what you had initially, you think there's no way I'm going to isolate this. Suddenly, little envelope flap, nothing fancy, rubber dam clamp on, rubber dam on, and everyone's a bit more relaxed, aren't they? Because you've suddenly got wonderful field that you can work in and do that proper dentistry.
Just a little bit of work before you get to the rubber dam, and sometimes we do need to just tidy things up a little bit before we put the clamp on. But that allowed me to do the root canal treatment, which was relatively straightforward, but it was quite a big canal, big apex. The picture on the left shows you me using a plugger, and I'm using it as my file. So it was quite a large apex, so it's a metal plugger, apex locator attached to it to get my zero reading, my working length, and then I used MTA putty in this case. Just because it was quite a long, straight canal. Again, really low bacterial load here. It was effectively a vital pulp. So really, really high chance of success, really clean. So I used the MTA plug and gave ourselves a bit of space for build up, which I did with a fiber post. What else could I've used here instead of that?
Well, I think it's really a lot of it. I mean, our view on posts is that we typically will choose a post that fits the canal space rather than drilling the route to fit the post. And so this here is, looking at this, is the Reliance 3D fiber post, which has got a taper to it. And actually, when you've got something that's relatively round as you had, I think is a really good fiber post choice. Typically, if we've got something a bit narrower, which we haven't here, but let's say we had something narrower, we might be choosing a 0.5 millimeter fiber post, a 1 millimeter post. You know, we've got a lot of different post diameters that we choose depending on the circumstance. Could you use a metal post? Yeah, I think you could, but the shape here for me doesn't quite match up, because you've got that cylindrical post, even if you're using the XT parapost.
True.
So I really like what you've done here. It's exactly how I would have done things as well.
Post. That's good. And then at this point is when we etch bonded and then placed the composite inside the SX retainer, the splint, and then some on the tooth, and then we just press the whole mold on the tooth and keep pressing to effectively make sure the composite seats as much as possible. Now, the difficulty at this stage is that I had to do a little soft tissue reflection, clamp, did the root filling, did the MTA plug, place the fiber post, and then I'm doing the composite, which was a procedure with this splint that I hadn't done before. So my flow wasn't smooth. And you can see here how I didn't press enough, or didn't load that splint enough. So you've got that cervical edge is a bit lacking, a bit short. And you can also see a little bit of cross-contamination of the tissue fluid in that composite. It's not perfect, I agree. So what I did, I just scored it a little bit and just flowed some more composite in there and just polished it back. Because I had the flap reflected, I could just polish that a little bit more. And that little nubbing that's coming out of the back of that tooth is the excess composite. That was heated composite as well, actually. So it flowed a little bit better. Monochrome, like one shade. I apologize for the lack of tints, but I had a few too many things in my head.
I think this is one of those cases where it's about securing a tooth in place. As you know, we said earlier, it's just taking this patient through to that restorative window where replacements become an option. And I think that's exactly, you want to take as many variables out of the equation as you can, really.
So that was a good sort of base. You know, there's as I said, when we do it next time, I would make a smaller channel, press more, put more composite in. This is just a flat back together, a couple of vicryl sutures in there. Probably, if I was to redo this, I could just bring the flap a little bit further, use monofilament sutures as a choice. I think I would. And then we reviewed this at 1 week. So 1 week later, it looked like this. Again, lots of polishing that can be improved, especially that midline. Soft tissues, apologies for the photos a bit high on this presentation. There's a bit of redness still there, but at 1 week, I'll be honest with you, I'll take that.
It's looking really good for 1 week. There's an interesting bit, isn't there, on this case, because we've got obviously a mirror reflected shot here, and it's very good of you to show this image, because it's showing perhaps, and actually it's probably one of the more interesting aspects of the case, is that it may look absolutely lovely for Instagram to look at the buccal and labial face of the tooth, but actually the palatal aspect, there's a bit of a void there, isn't there?
It's just, you know, this is where you can look at it and go, well, there's a bit of a void on that join bit between the palatal tooth and composite. Again, it's probably didn't load it enough, didn't press it enough, didn't put enough force. So this, and certainly there's a bit of shine through the post. Again, so maybe definitely should have cut the post back. The difficulty with this case, do you remember that deep overbite? That is what we really realized was very much in the way. So that's why I didn't have too much space. But absolutely, this is really good to see the things that can go wrong with this sort of procedure, because then I know next time that those are the things I'd be concentrating on a little bit more.
Absolutely. But I'd still think, when you look at this, what's this? This is a 3-month recall.
This is a 4-month recall? This was a 4-month recall, that PA. I'm happy endodontically that you can see that void that comes up on the PA. It's palatally and probably around the post as well. Again, a bit of probably lack of bonding. So what I would do next time is put a little bit more composite around the post first and inside the splint to get even more of a bond. And then Colin very kindly helped me to refine and polish the tooth. Patient was satisfied with the looks of it. There's lots of refinements that we can do, but he's still growing. Tissues are still maturing. There's still a bit of inflammation around that labial aspect that we can tweak. But there's a lot of moving pieces with him physiologically. And I think it's going to be a work in progress, or we just tweak it as we go along. But no, we might not need a veneer, we might not need a crown, we might not need an implant for a while, hopefully.
Yeah, absolutely. And I think looking at that, I know you're being super critical of your own work, as you often are. It's a lovely outcome from where the patient presented. Actually, I think the soft tissues look really pretty good considering where you were. And we'll come back to that point, buying this patient more time to get into that phase where all those options are on the table. So I think this is a really interesting case. Thank you for sharing it. And
very welcome. Nice to be grilled by you in front of this.
Absolutely, yeah. And hopefully everyone's enjoyed looking at Luca's case. And we will look forward to welcoming you guys back to another Underprepared podcast very soon. If you've got any topics or anything you would like us to talk about, feel free to comment below. And we'll see you next time.
Thank you.